So again, the cardiac arrest, it is estimated to occur 1 in 30,000 delivery, and it presents as a sudden collapse. And the causes could be like anesthetic complications, accidents, bleedings, and our 4 H's, 4 T's, hypertension. And this is very important that we have to have BLS, this diagrams put in your labor ward and working areas. If you see any patient that has collapsed, then you have to check for signs of life. And then if there are no signs of life, you should start with chest compressions 30 and 2 rescue breaths. And you have to do it until your resuscitation team arrives. And if you have AED, you can, after doing the initial resuscitation, you have to connect to the AED and check for the rhythm. And depending upon what AED advises, you can either shock the patient or continue with the CPR. So again, these are the important drugs that should be there on your labor ward, because these are very much required in the maternal collapse situations. So we always read about and listen about horror stories, but there are some good things as well. So here is a lady who was 47-year-old and conceived with IVF. She was 35 weeks pregnant, and now she has triplets in this pregnancy. And obviously she had preeclampsia and had an eclamptic fit. And so she started resuscitating the patient, and patient didn't respond to the initial resuscitative measures. So they did the perimortem cesarean section, and once the perimortem cesarean section was performed, patient started responding to the resuscitative measures. So again, it's very important that if the mother is not responding, then it is better to go for perimortem cesarean section wherever you are. You should not be shifting the patient to the theater. You just require a scalpel to perform this. And patient won't bleed because she has the cardiac arrest. And after once resuscitation is completed, and if the mother is stable, then you can shift her to the theater and suture, or you can suture at the same time. So this is the checklist. You need to have it in for the maternal collapse. And the eclampsia, I think day in, day out, I think all of us face this situation. So the eclampsia is defined as new onset of generalized tonic-clonic seizures or a coma in a patient with a preeclampsia. Incidence is very common, 27.5%. And so the diagnostic criteria for eclampsia is any woman with the convulsions during the pregnancy and first 10 days of postpartum, together with at least 2 of the features like either hypertension or proteinuria or abnormal laboratory tests, we have to label them as eclampsia. Again, always, whenever there is a fit in the pregnant lady, always first consider it as eclampsia and treat it, unless you know that she is already epileptic. So why are we worried about this eclampsia so much? Because 1 in 50 women with the eclampsia will die, and the stillbirth rate is about 22%, and the neonatal deaths are about 34%. So the risk factors, as we all know, it's a primiparity and chronic hypertension, chronic renal disease, thrombophilias. And how do we manage these patients? So it's mainly the supportive care, and most of the eclamptic seizures are self-limited. And it is very important that we secure the airway, and we have to maintain the patency of the airway, and we have to prevent the recurrent seizures. So patient should be turned into left lateral position, start supplementing high flow oxygen, 8 to 10 liters, and there should be suction device adjacent to the bed so that if there are any secretions, you can aspirate it, and raise the bed rails so that patient wouldn't fall at the time of the fit. And the treatment is you have to use the antihypertensives to reduce the hypertension. The drug of choice is the labetalol. You give 20 milligrams IV, wait for 10 minutes. If the BP is still high, more than 160, 110, then give her the second dose of labetalol, 40 milligrams. And if she doesn't respond still, you can go for 80 milligrams. And even after the third dose, there is no response, then you have to go for the next antihypertensive, that is the hydralazine. Hydralazine, the dose is about 5 to 10 milligrams. Again, wait for 20 minutes. Again, if there is no response, you can give another 10 milligrams. With the hydralazine, we have to be very careful. There is more hypotension, and the baby may be affected sometimes. And if the woman has just landed up in your clinic, she didn't have any IV access, then it is the nifedipine that you can give very quickly. 10 milligrams per orally, wait for 20 minutes, you can give 20 milligrams. If there is no response, you can give another 20 milligrams. If no response, go for another antihypertensive. So how do we prevent the recurrent seizures? That is by giving the magnesium sulfate through IV or the IM dose. And if there is magnesium resistant seizures, then we can use the higher dose of magnesium sulfate, or you can use the diazepam, lorazepam, or midazolam. And fetal monitoring is also important, and it's very important that we stabilize the mother. We should not rush with the delivery. Once the mother is stabilized only, we have to plan for the delivery. Whenever there is an eclamptic fit, there is usually bradycardia for about 3 to 5 minutes. It will recover. And if the bradycardia is not recovering, even after 10 to 15 minutes after maternal stabilization, then you can plan for cesarean section because she may be abrupting by that point.